Hello, we are going to get started. Welcome to session 10 of the Washington Healthcare Facilities Initiative webinar series. My name is Joanne McGriff, and I'm the Associate Director of the Center for Global Safe Water, Sanitation, and Hygiene at Emory University, also known as the CGSW. I'm also Assistant Research Professor in the Department of Global Health at the Rollins School of Public Health. Today, we are happy to have with us colleagues from UNICEF, WHO, Ghana Health Services, and the Serbian Ministry of Health, who will be talking about the actual steps to ensure access to Washington healthcare facilities. I'm joined today by members of our learning team, Ms. Lindsay Denny and Cassandra Savino. As you all know, this series is part of an action-oriented learning platform that seeks to, as you see in bolded red, connect, share, and act. We work to connect the expertise and experience of our partners and colleagues to WASH and health community members who are interested in moving to action in Washington healthcare facilities. We also provide a platform for the community of practice to share experiences, ideas, and best practices. And we encourage individuals and groups to take specific action to implement sustainable interventions that improve WASH conditions in healthcare facilities. So as usual, as we begin, I invite all of the meeting attendees to look at your chat box and to start introducing yourself by placing your name and organization. Please be aware, as you have been on this webinar series before, that it's important for you to select all attendees and not just all panelists, because we want everybody to see who you are. I will now just review some quick notes about the structure of the platform. In terms of structure, generally, we highlight a WASH in healthcare facilities subject matter expert in a 25-minute presentation, followed by 30 minutes of facilitated discussion. For today, the structure will be different. This month, we have 3 presenters, very fortunate to have them, as well as 2 commentators. So what will happen is that 2 of the presenters will speak for about 10 minutes, followed by a brief commentary, and then we'll open up for discussion. Then we'll have the next set of speaker and commentator, and then we'll close with a final speaker. Either way, I will introduce and also announce to you when we can begin the question and answer period. Otherwise, everything remains the same. Please be reminded that you and your colleagues will have access to webinar recordings, slides, learning materials, summaries, and action documents throughout our website at wnhcfaction.org. Also, please feel free to give questions and feedback to us via email at wnhcfaction@emory.edu. Also follow us on Twitter at WNHCFaction. I'll now pass it on to Lindsay Denny, who will provide a few additional reminders and recent Washington healthcare facility updates. And then after the announcements, I'll return to introduce the first set of speakers. Lindsay?
Good morning, everyone. Good afternoon. Great to speak to you all today. Before we get started, I do want to touch on the guiding principles that we follow when selecting topics and speakers for this webinar series. For those of you who have been here before, bear with me a moment. So we believe WASH is a fundamental prerequisite for quality of care within a healthcare facility. Secondly, we believe there cannot be effective infection prevention and control without adequate WASH in healthcare facilities. Thirdly, sustainability should be built into every WASH in healthcare facilities project from the very beginning, no matter the project size. And finally, WASH in healthcare facilities is not just about addressing issues at individual facilities. Multiple systems, sectors, and stakeholders must work together to see sustainable improvements. And this last piece is what we'll be focusing on in particular today. So a quick note about Zoom, feel free to use the chat box at any time to introduce yourself, ask questions, or make comments during presentation or interactive discussions. As Joanne said, please select all panelists and attendees so that everyone can see your note. And then during the session, the discussion sections, if you'd like to speak and you have the ability to use audio on your computer or phone, you can raise your hand. Please keep your hand raised until we call upon you, and then you can lower your hand. Bit of background about the sessions. The reason we are focusing so much on WASH in healthcare facilities is because sustainable goal number 3, health and well-being, and sustainable development goal number 6, water and sanitation, are both requiring WASH in healthcare facilities in order to be achieved. And last year, the UN Secretary General, Antonio Guterres, used the launch of the Water Action Decade in March to make a call to action for WASH and healthcare facilities. Leading into that, we have pulled together thus far 9 webinar sessions. We've done sessions on health systems, assessments, interventions, research, costing, national action, and technologies. And we also have one of those sessions, an extra session was done in French for your French colleagues. And all of those are available online. So for a quick update on news and happenings in WASH and healthcare facilities, it's been a really busy a busy month for all of us. In late May, about the week we had our last webinar series, WHO member states at the World Health Assembly passed a resolution on WASH and healthcare facilities, which urges governments to take action and partners to provide support. So this is an exciting step that we can be using in our advocacy efforts to move WASH and healthcare facilities forward and reach our goal of 100% coverage by 2030. In addition, last week, Global Health Council and Global Water 2020 hosted a commitments gathering in Washington, D.C., and thus far, 79 commitments have been made on WASH and healthcare facilities by a variety of actors to support member states in addressing WASH and healthcare facilities. So it's been a really exciting month, and we are happy to then move forward with talking to WHO and UNICEF. I will hand it back to you, Joanne.
Thank you so much, Lindsay. And again, welcome to session 10, entitled Back to Basics, Practical Steps for Countries to Ensure Universal Access to WASH and Healthcare Facilities. Again, I'm really delighted to have this wonderful panel of presenters and commentators. Today we have with us, in terms of presenters, Tom Slaymaker from the WHO UNICEF Joint Monitoring Program, or JMP, for water supply, sanitation, and hygiene. We have with us Dr. Maggie Montgomery from WASH and Health from WHO Geneva. We have with us Philippa Lysaght from Every Child Alive campaign, UNICEF New York. And also with us, we have our commentators, Gloria and Ntow-Kummi, WASH and IPC National Focal Point for the Ghana Health Services. And then we have Dr. Dragana Jovanovic, a hygiene specialist at the Institute of Public Health of Serbia. Again, really excited to hear from all of our speakers and commentators. So without further delay, I welcome Tom Slaymaker to begin the first presentation. Tom?
Okay, thank you. And I'll just check that everybody can see my slides.
Yes.
Okay, thanks for that introduction. I sit at UNICEF headquarters in New York, and I manage the UNICEF side of the Joint Monitoring Program together with Rick Johnston, who leads on the WHO side in Geneva. And we've been monitoring WASH in households for many years. We're now moving on to monitor WASH in schools and in healthcare facilities. So I'm going to give a very quick overview of what we found in our global baseline report, which came out in April. And I think, as Lindsay said, the framework for this is the Sustainable Development Goals. We have Goal 6, which is about universal access to safe drinking water, sanitation, and hygiene. And we interpret universal access to mean all settings, not just households, but schools, healthcare facilities, workplaces, other institutional settings. And of course, we also have Goal 3, which is about health, and there we have a target on universal health coverage. We don't yet have an indicator, a global indicator on WASH in healthcare facilities under the SDG framework, but we are already reporting this into member states in order to ensure that it receives the attention that it deserves. And this is in response to the call to action, which went out in 2018 from the Secretary General, and then WHO and UNICEF and others worked together to formulate a set of global targets focused on improving WASH in healthcare facilities around the world. Now, of course, in order to be able to assess current status and progress towards these targets, we need a baseline. And countries need to establish their baseline status in order to be able to determine what is a reasonable target at a national level, to be able to track progress going forward between now and 2030. So that's where the JMP comes in, and our job is to compile national data and use those national data to generate comparable estimates at the global level. We started by defining a set of core questions and indicators for monitoring WASH in healthcare facilities. This was a long conversation with a group of experts, trying to define a small number of questions and indicators that would be relevant in all settings. And those were published in 2016 and have been rolled out in a number of countries. And they're now available in all languages. In April, we published our global baseline report, and this came out alongside a companion volume, also produced by WHO and UNICEF, looking at the practical steps required to achieve universal access. So if you're not familiar with the JMP, we have service ladders, which we use to track progress. We have ladders for water, sanitation, hygiene, waste management, and environmental cleaning. And at the basic service level, we have definitions for each of these. We also define a limited level of service or no service at all for each of these domains. So a basic level of water service in a healthcare facility is water available from an improved source, which is located on premises. A basic sanitation service is an improved sanitation facility, which is usable at the time of the survey, with some additional criteria here that it should be facilities dedicated for staff, should be sex separated, with facilities for menstrual hygiene management, and there should be at least one toilet which is accessible for people with limited mobility. For hygiene, we're looking at both hand hygiene facilities at the point of care and also the availability of water and soap at the toilets. For waste management, we're looking at two main elements. We're looking at whether or not waste is safely segregated into at least 3 bins, so the separation of sharps and infectious from other general waste. And secondly, whether the waste is being safely treated and disposed of. And last but not least, environmental cleaning. This was added later in the conversation, given the recognition of its importance for infection prevention and control. And here we're focusing on whether there are protocols in place for cleaning and whether the staff who are responsible have received training. So you'll see the lower rungs on the ladder. The limited service means that there is something in place, but it's not meeting all of the criteria for a basic service. And no service is where the healthcare facility is really lacking in any kind of improved infrastructure, or is missing some major element in order to meet the criteria for a basic service. So we compile data from countries around the world, and we put these into what we call our country files. This is an example on the left from China. This is a complete list of all of the data that we are able to find for that country. The main national sources of data were facility-based surveys, but also to a lesser extent, health management information systems. And what we do is we extract the data from those national data sources and classify them using our standardized international classification. We produced estimates in this report for the period between 2000 and 2016. And the main stratifiers which we were able to make estimates for were for urban and rural healthcare facilities, for hospitals and non-hospitals. These are broad categories, but these were the ones that we were able to generate for most countries, and also for government and for non-government. Increasingly, I think in future we will start to look at different service areas within healthcare facilities, and we've highlighted a few examples in the report, but there's still a lot more work to do there. So very briefly, to give you a sense of the global headlines, when it comes to basic drinking water services, we were able to produce a global estimate, and that was 74% of healthcare facilities around the world with a basic water service. That means that that 1 in 4 still lack basic services. And the main difference here is between having an improved source and having an improved source that is located on premises or with water available. You can see in the case of Armenia, the vast majority have an improved source, but less than 40% located on premises. Similarly with Honduras, over 80% with an improved source, but less than 40% available at the time of the survey. So these are the limiting factors when it comes to drinking water services. For basic sanitation, again, it was difficult to make a global estimate meeting for the proportion of healthcare facilities meeting all of these criteria, but we were able to estimate the proportion with no sanitation service at all. So 1 in 5 globally with no sanitation service. It's quite a shocking figure. But these examples on the right-hand side will show you the data, the countries which did have data available for each of these criteria. And you see most countries have information on whether or not there is an improved facility and whether it is usable. But once you start to apply additional criteria for dedicated for staff, sex separated, menstrual hygiene, accessible for people with limited mobility, then you see that fewer and fewer countries are able to report, but also that the proportion of facilities meeting these criteria gets lower and lower. So in the bottom right-hand corner there, you can see that in some countries, very, very few healthcare facilities with sanitation, which is accessible for people with limited mobility. For basic hygiene, again, we couldn't produce a global estimate, but we were able to estimate that 1 in 6 healthcare facilities have no hygiene service. In countries where we are able to generate information, both on the availability of hand hygiene at the point of care and close to the toilets, we can start to analyze this for different wards within the healthcare facility. This is an interesting example from Malawi, and you can see there are quite big differences here between, for example, the delivery room, which was generally better, and, for example, the antenatal care ward or the child vaccination room. And, of course, the difference between having hygiene facilities available in some of those wards and in all points of care is quite a big difference. So where we do have data, we are able to generate disaggregated estimates for different wards within the facility. For basic healthcare waste management, it was very difficult to produce a global estimate, but we do have quite good data for least developed countries, particularly sub-Saharan Africa, where many countries have collected this information. And we can see that just 27% of healthcare facilities had basic healthcare waste management services. So they're segregating waste, and they're also safely disposing of that waste. We also see quite big differences between government and non-government in sub-Saharan Africa, and between hospitals and non-hospitals. Lastly, environmental cleaning. Very few countries are collecting this information. These are just 4 examples, but you can see that even in relatively middle-income countries and high-income countries, not all healthcare facilities have protocols for cleaning and staff who have received training. So the baseline report is focused on a basic minimum level of service which is required in healthcare facilities. Of course, there are many additional things that we would like to see in healthcare facilities. So we expect that additional indicators will be added in future, focusing on a range of different elements which would represent a higher rung on the ladder. For example, the quality of water, the quantity of water available, the number of toilets, actual hand washing practices. There is a long list of things which are identified in the report that could potentially be measured and monitored in future, not just in the outpatient settings, but in specific wards. But of course, the vast majority of countries do not yet have these data available, and so it's not yet possible to produce comparable estimates at the global level. In terms of the next steps, I think there's still a huge amount of work for us to do in order to harmonise the definitions that are used at the national level and to address data gaps. There are huge data gaps in all regions of the world, and in order to be able to establish the baseline status in all countries. And the first priority has got to be eliminating healthcare facilities with no service at all, and trying to get at least a basic minimum level of service in all facilities, large or small. But then progressively in future, we want to improve service levels above and beyond this basic level of service, and start to look at other elements which I think we'll all agree are important in order to maximise health outcomes, particularly for mothers and children. But with that very rapid overview, I'm going to hand back to our moderator. Thank you.
Thank you so much. Again, that was Tom Slaymaker from the UNICEF side of the JMP. I know we have some questions that people would like to ask you, Tom, but before we open up for discussion and questions, I'd like to invite Dr. Dragana Jovanovic from the Institute of Public Health of Serbia to give her remarks as well. Dr. Jovanovic, can you hear me?
Yes, thank you very much. Hello to everybody. Thank you very much for this opportunity to speak and share some Serbian experience and activities on improving washing healthcare facilities, the activities that we have been undertaking in Serbia. First of all, I would like just briefly to say that Serbia ratified the Protocol on Water and Health in 2013, and since then has been implementing national targets set under the protocol in line with its program of work that prioritizes, amongst others, the washing healthcare facilities, and is in line also with the Ostrava Declaration and the SDGs. In 2016, and 2017, Serbian Ministry of Health and the Institute of Public Health of Serbia, with the network of public health institutes, reviewed a methodology, national methodology for assessing the wash conditions in healthcare facilities, which is being conducted under the national program of the protection of the population against communicable diseases, and integrated the JMP wash core indicators for assessing washing healthcare facilities into a national surveillance system using existing resources and capacities, which means human, technical, and financial. What triggered this action? It is, I think it is interesting. Shortcomings in the monitoring methodology relating to unclear criteria for assessing washing healthcare facilities, poor data quality, data quality inconsistent with the proposed SDG core indicators related to washing healthcare facilities, rather qualitative assessment than quantitative, with limited interpretation of results, then weak implementation and enforcement in rural areas, incomplete coverage of healthcare facilities encompassing only secondary and tertiary level, and existing knowledge gaps related to drinking water quality, access to water and sanitation, sanitary and hygienic conditions in healthcare facilities, particularly in rural areas. The first results, the baseline data, actually, according the improved methodology and integrated JMP core indicators for assessing the washing healthcare facilities, came in 2018 and showed that the unsatisfactory sanitary and hygienic conditions, particularly for sanitation, which means that only 73% of investigated healthcare facilities met criteria for basic service. However, the baseline data was limited to secondary and tertiary healthcare facilities in urban settings only. The knowledge gap on unknown wash conditions in primary healthcare facilities in both urban and rural settings remained uncovered. This brought us to decision of undertaking a nationally representative survey targeting all types of healthcare facilities and settings, including primary healthcare facilities and in rural areas. And thanks to support of WHO, Serbian Ministry of Health, and our public health network, this survey is currently ongoing in Serbia, aiming at closing existing knowledge gaps with respect to provision of basic wash services in primary healthcare facilities, particularly in rural areas, aiming at developing indicators for advanced wash services at all healthcare facilities, and aiming at analyzing the legal framework and mechanisms for ensuring washing healthcare facilities, to allow for the development of targeted recommendations and measures for cost-effective improvement interventions. We expect that the results of this comprehensive survey, which employed the basic and advanced indicators for wash in healthcare facilities, in line with the latest JMP indicators for SDGs, will point to the shortcomings in providing an adequate wash conditions for achieving high quality of healthcare, and will serve for defining a national criteria for achieving an advanced service level in healthcare facilities, which will be further incorporated in and strengthen our national monitoring methodology and system. And at the end, we expect that the review of existing evidence, national policies, and implementation mechanisms related to washing healthcare facilities in Serbia will reveal policy gaps and bottlenecks and help in improving policy for providing better enabling environment to the provision of adequate wash services in healthcare facilities where both patients and staff will be safe. This is from Serbia. Thank you very much.
Great, thank you, Dr. Dragana Jovanovic from the Institute of Public Health of Serbia. We are now ready to open up the floor after this first set of speakers for some questions or comments or hand raises. So please feel free to type your questions into the chat box. Again, select all attendees and panelists, or you can use the raise your hand function on Zoom in order for us to call on you. Remember, only we can unmute you, so please keep your hand raised so that we can see you and then allow you to speak. Just a reminder for everyone, if we don't get to your chat box questions or your hands today, we will work with our speakers to respond to as many questions as possible that we will later post on our website. So, let's see. Okay, so we see that there are some shy people on the webinar today, but just in the interest of time, because we do have several other presenters and commentators who need to present, I'm just going to go ahead and move on to the next presenter, who for us will be Maggie Montgomery from WHO Geneva. Maggie, can you hear us?
Yes, I can hear you. Thank you.
Great.
I'm going to share my screen. Sorry for the delay. It's funny. Even though we practiced, it still takes me a minute. Can you see my screen now?
Absolutely, you're fine.
Okay, perfect. So thanks, Joanne and Lindsay and Tom. Really great to have that summary. Every time I hear JMP speak, I learn something new. So I think it's really impressive, and I encourage everybody on the call to really dig into the data, because there's so many nuances there about the different service levels, about the 5 different areas, and even at the country level, I think at least many of the health colleagues I've talked to didn't realize that you can actually go and download the country data sets, and Tom showed an example of one, but there you can find exactly where the data is coming from and look at many of the specifics that aren't in the global report. So I'm going to quickly talk a little bit about what's being done, what can be done. Tom already showed the slide on the basic target, and it was great to have Dragana speak about what's happening in Serbia, and especially looking at higher service levels, because we do recognize that even basic, there's still lots of gaps if countries have met basic, and it doesn't necessarily mean you've met all the minimum standards, and many countries are aiming and ought to be looking at how they can provide higher level of services. So we do have a target there, and we're very keen to learn from and also help countries work towards defining what those higher levels of services are. And of course, with things like antimicrobial resistance, increasing outbreaks on certain waterborne pathogens, there's certainly a need to do so. So WHO and UNICEF took a structured case study approach to see what is actually being done at the national level and what seems to be working. And from that, we gathered about 35 examples. We distilled it down into 8 practical steps. And these practical steps, I'm sure many of you have been engaged with and are familiar with, are to conduct a situational analysis and assessment. So that includes not only looking at what is the baseline data for access, but also looking at the policy, looking at the accountability structures, seeing where WASH in healthcare facilities is or is not positioned within the health sector. The second is about defining targets and having a clear roadmap. So I've just been looking at the new GLASS data, the Global Analysis and Assessment of Sanitation Drinking Water, and that report will be released in August. And it's really interesting to see that a lot of countries have targets for WASH in healthcare facilities, but many of these aren't realistic. If you compare the target of 100% to, say, baseline data that puts them at around 50%, and targets that, for example, are being set for much before 2030. So I think there's obviously a balancing act there, but also having a clear roadmap to how such targets will be met. In a matter of time, I'm not going to read through the rest of these, but what I will do in the next few slides is just present a few examples, and really happy that we have Ghana Health Service represented with Gloria to talk a little bit more about how Ghana has addressed several of these practical steps. So the next slide, sorry. Okay, next slide. So there's just a few examples, and what we find in countries, it's not a linear process, and many of these steps are being addressed simultaneously. Just to highlight a few examples of what's happening in quality. So there was a big report we produced last year on quality healthcare by WHO, World Bank, and OECD, and found that 8 million deaths could be prevented just by having better quality care. And Cambodia, Ethiopia, Kenya, Ghana, India, and Tanzania, they've all taken a systematic approach to embedding WASH in healthcare facilities indicators, standards, and monitoring and follow-up within their national quality package. And in some of these countries, that also is linked to a certification process around quality. We've also seen a number of countries embark on risk-based WASH improvement. So many of you are probably familiar with the WHO UNICEF Water and Sanitation for Healthcare Facility Improvement tool, which takes a systematic approach to looking at the deficiencies, what the risks are, what can be done immediately, and what requires longer-term planning. So some really fantastic examples emerging out of Cox's Bazar of the use of this tool, as well as the mobile app, because it is on a mobile app. And that work has now spread to all of Bangladesh. So it's really encouraging for us to see that emergencies, in some cases, could be a front runner because they potentially have more resources for certain emergencies to then spread and be used in more of a developmental context. Liberia in 2016 launched the National WASH Fit tool. So they took the WHO UNICEF one and adapted it and are implemented in all countries. And there's a number of other countries listed here that are starting to look at those improvements. I will say there are other tools available, and we are rather agnostic on the tool, but more about promoting an approach that prioritizes local needs as well as sets up a system to make sure that those needs are being addressed and monitored. On monitoring, there's lots of countries that are doing work on, for example, integrating one or more of the JMP indicators into their national health systems. Monitoring with the increasing use of DHIS2, there seems to be more space for indicators and more room to adapt even at the sub-national level. So that's really encouraging. And obviously we heard the example from Serbia. And then lastly, the importance of engaging communities. And I think that this is something within both WASH and health that I'm coming to understand is increasingly important, not only for their know-how, but also for the accountability that it provides. And hopefully Gloria will talk a little bit about the community scorecards as well as the use of local radio to engage communities and have a source of accountability. Sorry, I seem to have a hard time advancing. Okay, so bear with me. So Ghana. So all of these two examples I'm going to present, and several more are included in the practical actions document that is the companion to the baseline, but you can also find many more examples on the WASH and HCF.org website. So in Ghana, there was a few things that happened to kind of trigger the national work on WASH and healthcare facilities. First of all, a big study that found environmental interventions alone could prevent 90% of the outpatient visits. And at the same time, there were major updates happening to their health policy, their health financing strategy, and their quality. So this all allowed an opportunity to see, okay, how can WASH and healthcare facilities provide a quick win, but also be an investment that would pay back over time. So things that have been established were an intersectoral working group. They've developed a national strategy, most of which is being funded through domestic funds. They've updated their standards. And as I mentioned, they have a strong citizen engagement through the local radio and community scorecards. I think some of the challenges and opportunities, and hopefully Gloria can elaborate on these, is coordination. So for example, there's 71 training institutes alone on health, and also on safe management of healthcare waste. And this we find actually in a number of countries, how the waste issue is often underfunded, and it's often linked to the fact that waste generally, there's not a good system. And when you look at the fact that only 15% of the waste generated in the healthcare facilities is actually infectious, you realize that it's hard to address the healthcare waste alone without looking at the bigger solid waste issue and where most of the waste is headed. So one more example is again from Serbia. We heard a lot about what they've been doing on monitoring. I think on Serbia, what's really interesting is that the regional commitment that Dragana spoke about through the Water and Health Protocol has really helped propel the work at the national level, but also a lot of sharing in influencing amongst other countries in the European region. So we see that protocol, which is fairly unique in terms of its binding commitments and in terms of accountability, has really helped drive action. There's also been the increased work on monitoring and analysis has helped Serbia also identify that the underserved areas, which are primary and rural facilities, which again, as Tom mentioned, and which we see in the global data is common in many countries, are most left behind and more investments are needed in that area. So Lindsay mentioned at the beginning in the news and updates that the resolution on WASH and healthcare facilities was passed, and for us it's a really fantastic and exciting opportunity. Never before have we had a resolution on this issue, nor one that was so focused specifically what ministries of health need to do, but also on the importance of intersectoral engagement. So this was signed off and agreed by all 194 WHO member states. It does require that they report back every 2 years, and it commits them to doing a number of things, and many of these align with the practical actions. So things like conducting comprehensive national assessments, developing roadmaps, making sure, obviously, that WASH and HCF is integrated into health programming, especially around antimicrobial resistance and infection prevention control and child and maternal health. It also calls to make sure that funding's in place, and that WHO in particular also serves as an important actor to mobilize such funds. So commitments. I was happy to hear that Lindsay has confirmed that there was 79 commitments made last week, and for us that's really fantastic and encouraging. We are about to launch the commitments page on the knowledge portal, and this is looking not only to seek and track commitments, but also as a way for everyone to go and see what countries have committed, what partners have committed to help keep all stakeholders accountable. I've listed some commitments, specific commitments that we're seeking from different key stakeholders, such as the UN, the Ministry of Health, Water Sanitation, partners, financing institutions, as well as the private sector. And just wanted to state that as part of the World Health Assembly this year and the resolution, we had over 100 organizations pledge support for this work. So I think if we added up all the commitments, we would definitely reach over 100 so far. So with that, I'm going to end. I just want to encourage all of you on the call. You're obviously joined because you have a keen interest in this work, is to take a look at the resolution, and thanks for Lindsay for sharing the link, and see what elements are in there, and really think about within your own projects and your own work and your own countries, what has been done, what needs to be done to make that happen. Obviously, go check out the data. It's really rich, and I think is an important tool to help focus efforts, but also to identify where needs aren't being met. We, as I mentioned on the knowledge portal, it is an interactive portal. So you are able to go onto that site and share your commitments, share your tools, share your learning. So we thank all of those that have contributed so far. We have over 300 resources on the resource page that can be easily searched. There will be a number of webinars happening this year and next year, as well as a number of regional and global events, starting with the Global Meeting on WASH and Healthcare Facilities, which is happening in Zambia. We'll be having a number of ways to engage online before and after that event, so please stay tuned. And all of these announcements will be in the newsletter, which you can sign up for, again, by going to the knowledge portal. So with that, I will close, and thank you all for listening.
Great, thank you so much. Again, that was Maggie Montgomery from WHO Geneva, and we have our commentator, Gloria Ntow-Kummi from the Ghana Health Services, who will follow Maggie before we open up for questions. Gloria? You're still on mute?
Ntow-Kummi from Ghana Health Service, and then also work with the ministry. I'm the focal person, the national focal person for infection prevention and control. I think Maggie has said most of the things. The infection prevention and control program has been in existence for quite some time now. I started working at the national level from 2007. And as at the time that I was there, the program was already there, but it wasn't very vibrant as it were. And so we already had some working documents. We had a policy as at that time, but it was an old one which was developed in 2003. And we were not having much support as at that time. And so our work was mainly ad hoc. We do some advocacy, and then when facility managers are convinced, then they invite us to organize training and monitoring for their facility staffs. And this was mainly for bigger hospitals who have funds to be able to train all their staffs. And so that was how we were working previously until the Ebola outbreak that came in 2014. In fact, it was a good opportunity for us because we benefited a lot from that outbreak. Nationally, Ghana was preparing itself towards any eventuality of an outbreak. And so we took that opportunity to review our policy guideline and inculcated the hemorrhagic fevers also into our documents. And then we set up the structure from national level right through to the facility level. And so for the national level program is there, and then regions, and then the districts, and then the lower level sub-districts. And so the structure for IPC was refined during those processes. And then we were also able to work with our partners to also train all our health workers. We train all our regions, all the regional hospitals were trained, and then most of our district hospitals were also trained. And not only that, they were also had the opportunity of having a job aids to be able to help them with their training, to be able to implement effective IPC practices. And our monitoring tool was also reviewed during those processes. And so for the knowledge of IPC, it has gone way down in every region, and most of our facilities were informed and were implementing IPC practices way then. And so in 2016, we had an opportunity to also hear about WASH in healthcare facility. And so as a nation, we merged WASH with IPC to come out as WASH IPC. And then also we developed the technical guideline, national technical guidelines for WASH. We had some partners who helped us to do a baseline as at that time for only about 2 districts in our regions. And so we used that to develop a national guide for WASH in healthcare facility at that time. And then also we were also fortunate to have a national quality strategy as a nation. And so that was also part of it. We also have WASH in it as a strategy. And then also we have a national strategy on WASH to also be able to help us to have a way forward, to know where or how to roll up WASH in healthcare facilities. And one thing that helped us for facilities to be able to sustain the learning process was a system we call peer review. The peer review system was a system that had been developed in our various regions. And then peers, the facilities of the same level, assess themselves. And then in developing the peer review tool, we have infection prevention as a major component of the tool. And so facilities move to their peers. If one district hospital selected staff in the hospitals move to another district hospital to assess them. And then when they assess them, the regions coordinate all these activities and then organize a DEBA with community involvement where the results are shared and then awards and recognitions are given to deserving facilities. And so this developed a healthy competition amongst the facilities so that today, if I'm last, I wouldn't want to stay there. I want to be able to improve on my WASH and IPC services so that the next time I'll be able to come up. And so that has really helped us to be able to sustain that momentum for facilities to implement WASH infection prevention and control. I must say that WASH hasn't gone down so much as infection prevention and control, but we have done some orientation for our managers, our regional directors and facilitators. They have been oriented on WASH. And then also we also have put these indicators into our national district health information management so that WASH is reported nationwide. And so as I speak now, all the facilities are supposed to, we do it quarterly. They report on their WASH services into our national information management systems. And by so doing, we'll be able to come up and know as a nation where we are and then where we also need to get to. And then WASH has also been integrated into quality of care activities. Currently, the quality of care for maternal and newborn care, we have WASH featuring a lot in it. And it's also helping the lower facilities who were not part of the initial infection prevention and control program to also have a feel of it and also be trained and be exposed to it to help implement also WASH in healthcare facility. And so as a nation, this is what we are doing. And also, Maggie mentioned the community scorecard as part of the quality of care activities. And so community members have the feel of it. They are able to assess their experience of care within the health facility and also report on it. And so that is community involvement. We have been able to involve the communities. And so in areas that they need to support, in areas they are now as stakeholders. So once they know the health facility, and then they are also invited and they share their views, and their thoughts are accepted and they are invited into management decisions, then they are also able to offer support and give up their best. And so communities have been so excited. And a key example was one facility that we went to assess and realized that they had issues with their sanitation, their toilet facilities. We quickly involved the community, the chief and the elders in the community, who were not even aware that that was the situation in the health facility. Some of the chiefs were in the cities. And so going down to the lower levels, they were not directly involved in the communities. And so they didn't know that the facilities lack sanitation services. And by so doing, linking them to it, they've been able to support. And as I speak now, they are putting up a toilet facility for the community and then for the facility. And so community involvement, we have identified and realized that is very key when it comes to WASH in healthcare facility. And so that is the way forward now that we are going. And so in a nutshell, I think that is where Ghana is. And as at now, we are also reporting on WASH services into our National Health Information System. Thank you.
Great, thank you. That was Gloria Ntow-Kummi from the Ghana Health Services. And so now I will again open up the floor for questions, and this would be to any of the 4 speakers that we've just had. We do have a couple of questions since our speakers have been presenting. So I will start with the few that I do have in hand, but again, please write into your chat box your questions and we'll try to get to it before our final speaker and the close. So we have from Gloria, who is asking, and this is for Tom, how will countries be supported to improve on the ladder for WASH in healthcare facilities?
Tom, I think you're on mute.
You're on mute. Tom, I think you're still on mute. Tom, we can't hear you. Okay, while we try to get Tom back on, I'm going to move on. We do have a hand raise from Jesse Malotha. If we can move Jesse over, then we'll have Jesse ask his own question. Jesse, can you hear us? Jesse? Okay, so I think we're having trouble getting Jesse on. So then we do have a question from Jacob Nakwan, who states the starting point for WASH in baseline is a baseline survey. Are there country efforts in place apart from WHO and UNICEF to do these baseline surveys? Anyone can respond.
Sure, Joanne, this is Maggie. Can you hear me?
Yes, we can hear you, Maggie.
Okay, yeah, no, great question, Jacob. And I did, by the way, just reply to the other question about how countries will be supported in moving up the ladder, and happy to elaborate further as well on or offline. But in in terms of our countries doing these baseline assessment, very much, yes. So just to clarify, the WHO and UNICEF, they use and extract data by surveys that are already being conducted. So they don't do the surveys themselves. So many of those surveys were externally conducted, and some of the more well-known ones are SPA or SARA or SDI. But there are a number of countries, especially in PAHO, for example, in Euro, in parts of Asia, and now, as Gloria has just talked about, that are within their own monitoring systems are embedding WASH indicators and reviewing those and reporting on those. So hopefully, as this work and the indicators and the importance of this issue becomes more well embedded and known, there will be more and more data available. So yes, there are a number of countries, of partners outside the UN system that are all working towards having these baseline assessments done.
Great, thank you so much, Maggie. And again, I'll draw your attention to the chat box where Maggie did respond to the earlier question. But now I see that Jesse has some of the audio back on. Jesse, can you hear us and ask your question?
Yes, I can hear you.
Wonderful. Go ahead with your question.
Yes, of course. I'm the National Patient Safety Officer in Malawi, working with the Ministry of Health. And also I'm a dental surgeon working at a central hospital. Mine is not necessarily a question, but I wanted to make a comment. Like for Malawi, I think one of our biggest challenges is that we have healthcare workers that are committed to IPC and want to implement everything. But I think in our planning for the infrastructure, we never thought about those WASH facilities because we have a high turnover of patients. We have also guardians, people that are coming from the communities to take care of the patients. And now there are issues of antimicrobial resistance, healthcare acquired infections. And I think...
I'm so sorry, Jesse. Jesse, for some reason, your sound is not, there's a lot of interference with your sound and we're unable to hear you clearly.
Okay.
Oh, actually, if you would just continue now, we'll see maybe if the audio is restored. Try again.
All right. I was saying that in Malawi, I think one of our biggest challenges is planning for infrastructure design for our healthcare facilities. And I think this is an important lesson for us so that when we plan for such facilities, we need to take that into account. Because you can imagine you have dedicated staff that want to do all the hand hygiene and everything, but you have only one sink maybe for 60, 70 people. And that will not be helpful at all. So that is something that I think we need to take into account going forward so that we can all have access to WASH, IPC and everything so that we reduce all those healthcare associated infections as well as antimicrobial resistance.
Great. Thank you so much, Jesse, for your comments. I'm so glad we were able to hear you towards the end.
Thank you.
Of time, we have one final speaker that we would like to have a chance to make her brief presentation before we come to the final discussion and close. So we do have Philippa Lysaght from the UNICEF Every Child Alive campaign. You could have Philippa.
Hi, yeah, can you hear me?
Great, yes we can, Philippa. Please go ahead.
Great, perfect. Just timing-wise, do I have about 2 minutes?
Yes, you do.
Okay, I'll try and keep this quick then. So, hi, my name is Philippa. I'm with UNICEF, and I'm going to be talking about the Every Child Alive campaign. This is a campaign that brings together fundraising, policy advocacy, and public engagement. And the aim of the campaign is to support programs at a country level. The overall campaign looks to end preventable newborn deaths by ensuring access to quality, affordable healthcare for every mother and child. And of course, a big component in this is WASH in healthcare facilities. just to talk briefly about those three areas, in terms of advocacy, the activities aim to mobilise national governments to support child survival through policy changes, increased investment and scaling up relevant programs. So there is a 6-point policy change agenda, which I would be happy to share after this. And one of the points of that is the establishment of clean and functional health facilities with at least a basic level of wash services in the communities where women and children live. The second part, which is public engagement, looks to increase the overall support and to influence popular public opinion. So the campaign really targets mothers to take action to help ensure that every mother is able to deliver in a clean environment. And this picture here of these 6 newborns is just one of the many communications tools that we work with to engage the public. And then the third is resource mobilization. So here we're working with a lot of different parts of our organization and our partners to look at raising about 130 million in funds that will be targeted at programs in 10 countries. So if you could just flick to the next slide. Thank you so much. So this is just an example of how wash in healthcare facilities is part of a broader campaign. And the campaign is really focusing more on the child as UNICEF and the services that they will need. So just 2 very quick examples of how we really target wash in healthcare facilities as part of this campaign. One is evidence-based advocacy. So drawing on the information from Maggie and Tom, looking at the JMP and the work we do with WHO, we really try to focus this information, this evidence, and use it to advocate. So the headline message that we used as part of the campaign when the JMP was released was focused on the 17 million women who give birth in healthcare facilities with inadequate water, sanitation, and hygiene. And these are in the least developed countries. So with this sort of advocacy, we do a number of things. One would be high level, so our executive director delivering this message at the Sanitation and Water for All Ministers meeting, or the Secretary General who last week used this as an opening in one of his addresses. And the second way that we do this is through public engagement, and that's a photo campaign you can see here. So this was a series of photos with mothers across 4 different countries, and each photo highlighted the different elements that are needed for a mother to deliver in a clean and safe environment. And this was the example that was given for access to clean water, sanitation, and hygiene services. I'm going to leave it there because a lot of this information is available online, and I know we're short of time. I'll hand back to the moderator. Thanks.
Great, thank you so much. Again, that was Philippa Lysaght from UNICEF's Every Child Alive. And we have now come to the close of our webinar. We do realize that there are several questions in the chat box, and I know a number of you may still have some other questions you'll put in as we are closing. So we will do our best to work with all of our presenters and commentators to respond to these questions. As usual, we will post them on our website. Again, I want to give a really note of appreciation and thanks to all of our speakers who've come in from UNICEF and WHO, from the Institute of Public Health in Serbia, and from the Ghana Health Services. We really do thank you for joining us today and providing us with such great overviews and insights about what's happening globally. So I will now pass it on to Cassandra to close up with our wrap-up notes. Thank you so much, everyone.
Yes, and thank you again to all of our speakers for your wonderful presentations and comments. We will leave the chat box open for a few more minutes, so please feel free to post any additional questions you may have. We also encourage you to submit ideas for future webinar topics in the chat box or by emailing w&hcfaction@emory.edu. Today's recording, slides, and a summary document will be available within the next 2 weeks at w&hcfaction.org. These will include an overview of the session, any responses to unanswered chat box questions, and recommendations for action, as well as any of the resources that were shared by the panelists or in the chat box. We're looking forward to next month's webinar about the technical component of WASH in HCF with presenters from Engineers Without Borders. Thank you so much again for your participation today.